So thank you for being back on the show.
I'm so glad to be back on the show.
Yeah, our conversations are some of my favorites, and I know it's been years, but I'm really really glad to have you back. So talk to me a little bit about why this topic. I mean, obviously it's Movember, right? It's men's sexual health or health awareness, but why are you particularly interested in the
Yeah.
conversation around prostate cancer and sexual health?
Well, actually, my dad had prostate cancer years ago. It's actually back now.
Oh,
But he's also, 87. So, um, and what I learned from that, along with many patients, is that they don't really get a lot of information that is about sex, the
mm,
sexual health, and what they should be doing, like not even just psychologically and behaviorally, but also physically,
mm,
right? So they don't, not everybody's comfortable talking about it, as you know, with this whole
yeah.
podcast. And it's
I,
hard on men. They feel more, they're less masculine. They feel like vulnerable because they're not in the culture to kind of talk about some of these things. And really they've been reassured by erections for so long, like everything's going okay. And so when something like this happens, it feels like the rug's pulled out from under them.
yeah. I think we expect our doctors to talk about this stuff and have knowledge about this stuff. And it is so disheartening when they don't, or if maybe they just undervalue sexual health. Like, hey, we're going to save your life here, but not really thinking about quality of life, you know?
Yeah, well, actually, I mean, I can think it depends on the doctor, right? It
Yeah,
really
yeah.
does depend on the doctor. And certainly first, like if we're talking about the impact of prostate cancer, cancer control is the first thing that's primary. And then
Yes.
actually, so like if somebody has most, really, I want to say the most common is radical prostatectomy, which is the surgery.
Hmm.
And um the two common symptoms then would be urinary incontinence and sexual functioning. So those are like, I would say cancer control and then urinary control and then sexual functioning. And honestly, sexual functioning takes the longest to get under control.
Okay.
Yeah, like urinary control can take months. And it really could go up to even a year. At a year, they probably look at some other, medicines and other even surgeries to help with that. Um, and it depends, the urinary control depends on the if the person's gotten pelvic floor therapy, if they've pelvic floor physical therapy,
Right,
right?
right, right.
And then how their preoperative functioning is and or how it was, and then the extent of the cancer. But the sexual functioning takes the longest. So in other words, it might take 2 to 3 years to recover, and it's based on somebody's age. It's based on the penile rehab that we're going to talk about, somebody's overall health. Like if they are overweight and smoking and drinking, it's going to be a little more difficult. And then with the prostatectomy, if they've had nerve sparing procedure, and really again is the quality of the erections prior to surgery, right? So that's kind of like their baseline.
Right, right. That's a lot. Those are a lot of factors to think about, like in
Yeah.
terms of variation of outcome, perhaps.
Yeah.
So, besides the physical ability to get an erection, which again, you're sort of addressing all these different factors that could impact that. What other kinds of
Yeah.
impacts happen from this treatment?
Right. So I think of like if we just go back to kind of dividing this into desire, arousal, and orgasm, sort of the
Okay.
kind of way to think about it, I think. Desire would be somebody's thoughts and fantasy. And then arousal is going to be blood flow with erections. And then orgasm are the contractions every 8/10 of a second in the pelvic floor. So for desire, the thoughts and fantasy, people after prostatectomy are less responsive to something they would see that normally would turn them on, uh,
Okay.
or you know, yeah, or even, yeah, basically, and they would have decreased fantasies,
Is
arousal. Yes, go ahead.
Can I ask, like, why? Why would somebody be less mentally?
Well, they,
desirous of sex? Is it
yeah,
just because of the knowledge of the physical impacts or the stress of this?
yeah, no, it is physical impact of the treatment, right? Because
Okay.
there are some of the, well, there's actually, we're going to talk about the difference between this is prostatectomy versus radiation. And radiation comes with a lot of times androgen deprivation therapy, which really lowers their testosterone.
Okay.
So, you know, with this, if it's with the prostatectomy, if it's localized, they can basically do surgery and remove the prostate. So it
Right.
does really, it's a physical, it's not just psychological impact, right? But
Right.
we know that obviously if you do, I shouldn't say obviously, as you know, if we come at it from all angles, it's really going to be the best bet. And this is,
Right.
I think when I think of sexual health, because I work with all different subjects,
Hmm.
I would say this is a perfect example of how really, one of the things we're going to talk about is how they need to continue to engage. That is important both psychologically and physically.
Yeah. Yeah. Yeah.
Just look, yeah. So desire goes down with prostatectomy,
Okay.
and um, the ability to get an erection for a longer time, maybe the need for longer stimulation. And then the orgasm is what we call dry orgasm. It's without ejaculation. And there's also a lot of times an involuntary loss of urine during orgasm or erection, which is
Hmm.
very upsetting to people.
Okay.
Um, and the orgasm changes a lot of times. It can some report it actually is more strong, and then
Huh.
other report it's more muted. Um, but it's usually reported that it's pleasurable, but it's different. Like one guy said that it was kind of an overall body experience. Um, and the pain can actually happen with some men. It's not as many, there's less, like few men,
Okay.
but over time they're able to get that. Um, they're able to improve that, right? It takes longer to
Okay.
orgasm, and the refractory time is longer. So in other words, to go to the second orgasm, that's going to take more
Right.
time.
Okay. So all of these things are going to shift. And then you sort of alluded to this, but what's different with radiation versus prostatectomy?
Right. So radiation, they've really similar, similar impact, but all of those symptoms start months or even years after the radiation is done. So like that impact is delayed.
Oh,
Uh,
okay.
and it can cause, the blood vessels and the nerves can cause difficulty over time. There might be fertility issues with motility, lower desire, and that is especially true if it's paired with the androgen deprivation therapy. That is, and that's even compared to prostatectomy. So that is really decreases somebody's desire.
Yeah.
And then the loss of ejaculate, there's much less ejaculate, which of course brings up a lot of grief and loss, but with the prostatectomy, there's no ejaculate. That ejaculate goes up into the bladder. So
Right.
here it's just less.
Okay.
Um, yeah. So there's a lot of grief and loss. Like we're,
Yeah. I mean, I say this to clients all the time, like any change involves loss, and it's okay to grieve that. And this is big, big change, right? Big changes for people.
yes. Yeah.
Yeah.
And I think that when I think of arousal, like lubrication and erections, they've served as like a sexual cue for people to you're engaging with somebody and you think, okay, everything's working.
Yeah, they're into this. Yeah.
Yeah, if I'm Joe Memphis, I can see I'm getting an erection and it's all going well. And she is lubricated or my partner's getting turned on. So it's a very different because yes, it's a very different because really what we're asking them to do a lot of times is to engage without that arousal that is visible,
Yeah.
right?
Yeah.
So
Yeah.
it's definitely different.
Right. Okay. So if we're going to think of this as desire, arousal, orgasm, how do you help people or recommend people sort of work on desire?
Yeah. So desire, you know, I have no doubt that you have talked about responsive desire in
Yeah.
your podcast where just for people maybe that didn't hear that one or those, because I know it comes up all the time.
Yes, it does.
Really, typically, a lot of women in long-term relationships, we think of that as more responsive desire. So, in other words, they're not spontaneous desire. They're ready to rip somebody's clothes off at the beginning of the space. You see it in women, you see it in, at the beginning of a relationship often. But, um, for women in longer term relationships, usually they get that arousal in process, right? And I don't want to just say for women, right? Because I
Oh yeah,
think
I definitely have this come up with men too. It's less
exactly.
gendered than we think, I think.
Yeah, I agree with you, right? So what happens is that if you've got a guy that has had spontaneous desire, in other words, I'm Joe Memphis and I see somebody, I'm ready to rip somebody's clothes off, and that's kind of what it looks like all the time, then I might shift to sort of having this desire in process, which means I've got to get myself in there before I'm aroused. So that's a
Mm,
little bit tricky, right?
yeah.
Because they got to get themselves in that space. And, you know, I think normally there's barriers, what we think of to responsive desire. Like somebody could say, I have a neutral feeling, but you know what? I have thinking about influence of like past trauma, or I'm thinking about body image, or I'm thinking about all
Mm,
those things. And so when we talk about men having this desire, they think I have a neutral feeling, right? I'm not getting this erection where I'm going to put somebody's
right.
clothes up, but I might leak urine, or
Uh,
I not going to be able to have penetrative sex anyway. So what's the use? Or I might not be able to orgasm. So why am I doing this? Or my orgasm might not feel as strong. Or why am I doing this? Or penile, actually, I don't think I said this, but penis size can be smaller. It can be a little bit shaped differently. Once in a while, it's different color, but not usually. It's mostly that the size is an issue. But we're going to talk about what to do about that.
yeah,
Um,
yeah.
so they think, oh, I can't please my partner because let's just forget it, right? I'm not going to be
Right,
able to.
right. I'm going to disappoint my partner or let them down, or maybe my partner
Yeah,
is unhappy about this or something. Yeah.
exactly. So they haven't really been told about this responsive desire to even look for it, right? And so the takeaway here is that men should not really wait for a biological drive to engage. It's really
Yeah.
going to be healthy, important for them to, stay tuned in and really think about what's pleasurable, right? You're going for, again, which I know are echoed in your information. We're going for pleasure as a measure, what every sex therapist says,
Yeah, yeah.
right? And you're gonna pick that. You have to trust you're gonna likely pick up that desire in process, or you're gonna have a really good experience,
Yeah.
either way.
Yeah. Yeah. Okay, so that's maybe the willingness and desire to engage at all. What helps with the physical side? And you mentioned this could take years to recover. So,
Yes,
yeah.
it is a bit of time. So um I think so if we're just looking at physical and we're just looking at like, because your men on here are going to be like, show me the money. Like, what exactly do I need to do?
Yeah.
And so actually engaging, whether they're by themselves or whether they're partnered, the vacuum erection device, where we call it a VED, and the your intercavernous injections, those two things, like versus like the medicines, the PD5 inhibitors that people have heard of, like Cialis or Viagra, those things, there's actually a reason for them to be on that in addition to this. But if
Yeah.
they're just trying to get the erection in the moment, they will not work until the guy has about, and I shouldn't say guy, the penis owner, until the penis owner has about 50% of an erection, that those will help,
Right.
right?
Because I say this to a lot of people, those medications do not give you an erection. They help you keep the erection, right? They help keep the blood in the penis.
That's correct. But I would say they're not going to be as effective. They're not going to be the go-to right after the treatment, the prostatectomy.
Okay.
It would be better to go to either the intercavernous injection, which a lot of guys are like, "Oh my goodness,
A needle
that
in my
sounds
penis? Yeah.
terrible." Right. But then once they do it, they're like, "Okay, they get it." And it is more effective. So either that or the vacuum pump.
Okay.
As opposed to right? The Cialis and some of the things that we think of. And then really the main thing I would say, now, yeah, the main thing I would say is this penile rehab, right?
Okay.
Which we are, so what happens is, so if we just talk about that for a second, what happens is every 90 minutes during the REM stage of sleep, if a guy's healthy, he's going to get an erection every 90 minutes,
Okay.
about for about 10 minutes. And so his penis is getting like good exercise every night. It's getting like blood
Yeah.
flow, healthy blood flow, and surgery and medication can interrupt these erections.
Okay.
So suddenly the guy is, after he's getting this treatment, is not getting that blood flow.
Mm.
So that's the reason that it's really important. And so when we talk about penile blood flow, what we're talking about is a combination of methods to encourage blood flow to the penis. And we're really trying to keep the blood vessels and the tissue healthy. Now, what gets a little confusing is not everybody describes it the same way, right? And I think it
Okay.
might be a little easier if maybe there was like a standard, but there's really not. So in other words, it will depend on which doctor, which facility, and really honestly, hopefully they're doing something because
Yeah.
still
Yeah.
a lot of times it's not prioritized. I think sometimes what happens is they don't think that the patients are willing to do the trouble, but I believe
Uh,
that the men for their penis would,
are
you
pretty
know?
motivated, right, to
Yeah,
regain sexual function. Yeah.
exactly. So you remember the methods that we talked about, like the penile pump and the injection and those things, like the medicines, the
Hmm.
Viagra. Um, So really, if I gave you, and I like giving the sample of University of Michigan's penile rehab program, because they are just fabulous, as we know.
Right.
Both of us were there for their sexual health program. So what they suggest is the penile pump 3 times a week. So the man would be using that, keep the pump on for about 10 minutes. And the prelude pump, which we can come back to, but it's a specific kind of pump that's not used for penetrative sex, but um, it's used for health,
Okay.
basically. And really older men can use it too. And then they do a Cialis Viagra type medicine every other day. And they suggest daily masturbation if the person is willing. Really, any amount is good because they're encouraging blood flow, which means you can do that with a partner, you can do it by yourself.
But that
And
would be without the pump, without the mechanical device. That would be manual stimulation, oral, something, right?
or they could use the penile pump, the one that is just the regular penile pump, not the prelude pump. The difference is that that prelude pump doesn't have a ring to keep the blood flow in. So if
Ah,
the man is going to masturbate or partner, he's better with that VED device, the penile pump, the regular
okay.
penile pump. So
Okay.
that's a good question. Yes. So what happens is, that's Michigan's plan, and they suggest you kind of start this 3 weeks after the catheter's pulled from that operation. So it's
Okay.
very soon. That's the key, like
Yeah.
soon in. But there's other like Sloan Kettering really uses the intercavernous injections as a part of their plan, right?
Okay.
And I think of Elise Fossite, who also uses those as a part of her plan, which she's just so smart. Um, so these are really critical. This whole penile rehab plan, it's important because, it improves the ability of man to get these natural erections over time. And actually,
Okay.
when he does get them, when he starts to get those nighttime erections, then he could lay off of this, right? That's how you know when you're done. You would do it at
Okay.
least three months for sure, but it may take a year or 2 years for them to be doing this until they see a result. Um, and so it also prevents shrinkage and scarring, and it helps with size. So this is the thing that helps with size. Um, but what happens is people prematurely stop it because they don't see an erection in the moment. And
Mm,
the key is you got to keep
it's going
doing
to
it.
take some time. Yeah.
Yeah. And if somebody tells you that their penile rehab is just take the Cialis every day, that is not penile rehab. right?
Right. Because you've got to be drawing blood into the penis somehow on purpose, right? Like
Yeah.
that's the whole point of this is
Well,
to,
that does, but it actually creates blood flow to your whole body, which is why you
uh,
see guys like get red flush face or they
uh,
get like headaches, you know. Um, but really, I don't know. I can't remember what I was just saying.
okay, but so basically in a healthy male, he's having erections every 90 minutes while he's sleeping, but once a day to masturbate,
Yes.
3 times a
Yes.
day or 3 times a week, specifically with the pump or with the injections. Like you've got to decide which one of those you're
Well, the
doing.
pump is 3 times a week,
Okay.
right? So that could be engaging or by yourself or whatever. You don't even
Right.
have to
Okay.
orgasm. You don't have to orgasm. I think it's important to mention, I don't want to get off track, but it's important to mention that men will orgasm without a rigid penis, right?
Yes,
So
it's two
know
separate
that.
processes. Yes. Yeah.
That's right. So men sometimes that's all new to them, right? They
Yeah.
can orgasm with enough direct stimulation, even if they're not erect. So 3 times a week with the penile pump is Michigan's plan. Prelude pump on every day that that's not used.
Uh,
Okay. So they're using a pump of some kind every single day. 3 times a week is the specific one that they could masturbate with that'll keep the blood flow in or that
okay.
they can partner with. And then PD5 inhibitor, the Cialis every other day, and masturbation every day if the person's willing. So that
Okay.
is like the whole plan. Like I said, Sloan Kettering, they work in the shots. There's
Right.
some
Right. Right.
doctors that really feel like those shots need to be a part of it because it's a different kind of blood flow, right?
Yeah. Yeah.
Get arterial blood flow when they're doing that, right? That's a different kind of blood flow than venous blood flow. So yeah, and
Interesting.
some doctors actually even start this um, before the surgery, right? They're trying to get the person get their functioning up and get
Yeah.
them.
Yeah. So for people that maybe had some sort of functioning effect already, right? Some sort of ED or some sort of
Yeah,
slowing down,
yeah,
maybe to do this before.
yeah, and help them, right?
Yeah.
The penile pump, you can find that at a place called U, like the letter U, and we can put this in the notes, I guess, but youandme.com.
Mm.
And she will help you get that penile pump. So it's much
Yeah.
easier to use. So that's why some men like it, that they wouldn't necessarily use the other one all the time. Might use this one because it's easier.
Yeah.
Uh, but they really, and I do suggest people that are aging to use that pump too,
Right.
uh, as a healthy thing. But I think I don't know. I want to just take a second to tell you, I'm so glad you're talking about this because if men are told what to expect, then they're
Yeah.
going to be much better. Their sense of loss and anger and sadness, I mean, less
Yeah. At
mask.
least there's some agency they have here, some power to do something and, affect the result, which is,
Yeah.
I would imagine, feels really, really good.
Yeah.
Yeah.
So thank you. Thank you.
Okay.
You're like an
So,
advocate across lots of topics with this. So I like
yeah.
feel grateful and I definitely send my patients to your podcast because they have an expert that knows the answers half the time anyway, more than half the time, right? You already know this. You're just being polite to me.
Yeah. All right. So start early.
Yeah.
Do this really, really consistently, and you may have to do it longer than you would expect, right? Don't give up too early. That this could be a bit of a long road in terms of rehab.
Yeah, this is a long road. This is a long road.
Okay.
And that's I want to say too, I'm sorry for anybody that's listening to this who has prostate cancer or somebody that they love because you hear the word cancer, it's scary, you
Yeah.
know?
Yeah.
Yeah.
Yeah. Um, and how common, I mean, how often are people even being told about rehab? Like, we were talking about this a little bit before we hit record that younger doctors maybe are a little more on top of this than the old
Yeah.
guard. But
Yeah. Yeah, it depends. I mean, it really depends. I don't know. I mean, you and I heard this probably 2017 or something like that, but I don't know that it's being emphasized. There has been not one patient that I've seen in my office who has been told about all of this. This is my
mhm,
private office, right? Separate than
yeah,
University of Tennessee. I'm at University of Tennessee and they really supported this program to be able to do a video program for their patients, which was
yeah,
great.
Yeah.
So different than their group because they are being told. But in my office where we just get different people, urologists, they're not really being told the way that I'm explaining this.
Yeah. Is it ever too late to start? I mean, because you're definitely saying, hey, earlier is better. But if somebody was not told about this and there can't, it's been a while, could they
Yeah,
still do it and
I would
benefit?
say it's never too late to start. They
Okay.
really should go ahead and start the penile rehab if they're not getting erections in the nighttime, right? That is
Yeah.
really important. And really for like radiation therapy and the for the androgen deprivation therapy, a lot of times they are not waiting. We don't suggest that they wait until, because remember, what gradually
Yeah.
starts. Don't wait until then. Start to use it, right? Start to engage in the penile rehab. Get that pump going
Right.
and the Cialis and everything, all the pieces.
Okay. And once those sort of organic or spontaneous, whatever you call them, erections start to happen at night, you just drop the rehab entirely or you sort of wean off of it?
I would say slowly kind of see where you are, right? And
Yeah.
we're trying to keep the health of the penis, right?
Right. Right.
And it, helps all these different things.
Okay. What about tips? You mentioned incontinence could take up to a
Yeah.
year,
Yeah.
perhaps, and I think you said that could be more likely to happen with an erection or with an orgasm, like in a sexual encounter with a partner.
Yeah. So
Any,
that's
yeah,
hard, right?
yeah,
That is and it does require kind of a shift in thinking for people because they might be, we're socialized to think, oh, that's not good. You know what I mean? Like this is not a good thing. And
right,
you have to kind of, I don't know, you have to kind of start to think about it and what is important. You don't want to let go of sexually connecting because of being self-conscious about that. So
yeah,
one of the things they might do is really the thing that's going to help that the most is the pelvic floor physical therapy. So they want to
okay,
get referral for that. That helps with leakage and it improves control. They can empty their bladder before they're engaging. Uh,
mm-hmm.
certain positions, like being upright, that can reduce pressure on the bladder, so it lessens leakage. And if they're able to get erect enough that they can stick a condom on, that also can maybe give them a little bit more of a better space in their mind.
Yeah, a little peace of mind about
Yeah,
that.
and
Yeah,
they could engage in the shower. That is another idea. And,
mm-hmm.
if they're using a lubricant, that sometimes can disguise, what's happening. And I always am careful about how to say this, but I think I'm just going to say it to you, Jessica. Um, I, they make these nice waterproof throws that are just, nice and soft. Those, when you buy those, like if you look up a brand, which I'm not going to mention, but it's very overpriced. But if you look at it for like a little puppy, or if you look at it for like something else, right? If you look at it for something else, it is actually much less priced. So, well, you know what? Men are practical, so I'm just gonna go
Okay,
ahead and tell them you can find that if you look at different, you're looking for a waterproof throw. I would just
right,
look on wherever you're looking things up.
okay, right. More ease of mind or mitigating the
Yes,
the impacts of that.
exactly.
Okay. Okay. Is there anything that men can do, penis owners can do around the changes in orgasm? Is that something that also comes back
Yeah.
the way it used to or can be improved, or is that something just to adjust to?
Yeah. So I would say, really, desire and orgasm, it really is a kind of a mind shift. And now we are talking about the psychological piece, really, because you think about it when it goes really to that, how men are socialized, that basically men are socialized to make sure that there's a lot of pressure on men to make
Yeah.
sure, and it impacts how they approach sex and how they approach sexual dysfunction. So it really, it's there are women or partners, right? Gay men. There might be men or any partner,
Hmm.
basically, that puts like, why are you not attracted to me? Right. I see that
Ah,
happening more with kind of somebody that has erection difficulties, but not prostate cancer,
yeah,
right?
yeah,
Less
yeah.
likely to, we all fill in the blanks with our dysfunction, it's like it must be me.
Right.
Okay. But honestly, in all of those situations, where the man has prostate cancer or not, the men are putting so much more pressure on themselves,
Yeah.
make everything perfect. And there's a little bit of a black and white thinking, like, an erection from everybody. Erection means the person's turned on, and
Hmm.
that's full erection. That's what I need to have happen. And
Right.
orgasm means it's ejaculating out of the penis. So we're already saying there's an issue, and it impacts how men approach sexual dysfunction. For example, when they first released Viagra a million years ago, um, that they only 50% of the men refilled their prescriptions
Yeah.
because they, they basically weren't explained how it was supposed to work. And really, as you know, you're supposed to take it, and you have to, maybe give it a little bit of time, but then you have to engage, right?
Right.
And
Right.
so the men were waiting for their erection, so they're not getting in there, which it's all because of this socialization where they need to have things,
Yeah.
perfect. They're waiting for their erection. They might masturbate on their own. How is my erection? And this whole plan is different than that. What we would want is really men to engage with the semi-rigid penis, to be able to, or no erection,
Yeah.
right? And that's hard to hear, but you don't want to wait if you're not getting your erections back, at full erection until like 2 or 3 years. You don't want to cut your partner off from
Hmm.
that. And so the idea is to don't, not panic, and to engage with semi-rigid or not rigid. Expect that you're going to get waxing and waning erections. That erection may not stay. You may or may not orgasm. We're looking for skin to skin contact. You may orgasm, actually, because we talked about that, right? But
Right. You
it's
don't need
difficult
the
to start.
erection. Yeah.
Exactly, exactly. And so they can shift to, another mistake I think would be maybe waiting until they can have penetrative sex, because I know we sort of have this high value on
Yeah.
penetrative sex, right?
Right.
It's
Right.
like that is what real sex is, and anything else is second class sex, or this is what I did as a kid. You know what? This is, you
It
know,
all counts. Yeah.
very valid, and it's very valid sex. So it might be providing manual stimulation. Somebody provides either himself, but if he's partnered, somebody provides manual stimulation. Could be oral stimulation, with or without a condom on,
Hmm.
right? And again, don't worry, like, oh my goodness, that's going to be not enough stimulation because I'm not going to orgasm. You know what? You're going for pleasure.
Yeah.
Man can rub his penis against the partner, or man can stimulate himself with the
Yeah.
partner present. It's about the connection. And then I think of, the fact that we're talking about pleasure-based sex. This is the key, really, and staying flexible over, flexible with your thinking. Be an expert at non-genital touch. Like, what does that mean? Maybe take an eye mask and have your partner touch. I would put boxers on at least, and have your partner rub something against your arms and then your legs, so that you really learn with the eye mask how to tune in. How do you become an expert at receiving? It's really tuning in, right? And you know, take turns, maybe use a toy. There might be better timing for somebody that is,
Right.
I do better in the morning, but the key is to kind of get creative and stay away from the evaluating moment. How's my penis? How's my penis? And
Yeah.
get into the erotic moment or their fantasy, right? Their fantasy. We know people do better with orgasms when they have the ability to fantasize. Stay tuned in. And we always say, right, your mind is your most important sex organ. We
Yes.
always say that, right?
Right. Right. So this, all of these suggestions seem especially important, even more important for people that maybe aren't going to regain sexual function. You mentioned like nerve sparing surgery, and there must be cases where it just is not going to happen.
So I think all those are going to be important in terms of anybody getting their functioning back, right? So no matter, even if this is like the best scenario we can think of, right? Which they very well might be in, right? But everybody needs to be doing these things. And
Right.
because they're not going to just have the erection, or even just take a Cialis and get the erection soon
Right.
after. And what they're doing is, by engaging, that's helping them psychologically, like getting comfortable, being, open enough that you can share that space with somebody. And learning how to work with somebody, when we should actually talk about partners some because they got to
Yeah,
learn
yeah.
how to do that. Um, but it's also physically helping them too,
Right.
right? This is physically important for them, and they are at a compromise, certainly for a little while, with this. It's not, I don't mean to sound like Debbie Downer, but it is not an easy space, right? We're
Right.
saying
Right.
it hits men in a particularly hard space. That was what
Yeah.
I.
Yeah. Do you know any stats about how many regain what percentage of men regain sexual functioning after
You know what? I
prostatectomy?
don't. I don't, and I don't want
Okay.
to. I don't want to
Yeah,
say it's
don't make
wrong.
something up, right? Okay.
Oh yeah, no.
Right. But the bottom line is there's going to be value in doing this no matter what your ultimate
Exactly.
outcome is. Yeah.
And this is what I was saying, like when we talk about like, we're always talking about behavioral and psychological things, and this is where they really overlap. Like you can see a biopsychosocial approach is the only way to do this
Yeah.
because you really, doing the penile rehab, engaging with someone, that all is psychologically and physically beneficial. We're not just
Right.
talking about psychologically. It's physically better for
Right.
them to be engaging, like
Okay.
engaging with themselves or partnered, either way.
Yeah. All right. So let's talk about partners a little bit. What are some
Sure.
suggestions, some tips, some things for them to really be aware of and focus on?
Yeah, actually, I think a bad plan would be, like we said, stopping the penile rehab, distancing themselves from each other, which sometimes happens
Yeah.
uh, without information, and they just stop engaging altogether. And then people get depressed and sad, or you blame yourself, or you blame your partner, right? So, one of the things that might be helpful for them to understand is the partners. I think it's always helpful for the partners to understand that concept of genital non-concordance, right? I know you know that, but it's
I
like,
do, but would you
yeah,
define that for
I
the
will,
listening
yeah,
audience?
yes. It is like where your genitals don't match your mind. So somebody
Yeah.
could be very turned on and their body could be, you know, not functioning, or your penis could be functioning, or vulva lubrication could be in high gear, and your mind wouldn't be turned on, right? So,
Yeah.
what does
Yeah.
that mean? Like, if we gave actually an example of both of those things, if there's an assault, maybe this is not positive, but if there's an assault, we know that a lot of times women or men will have that lubrication or erection response if they are the one being assaulted because it's a protective response. And that's, we know they're not turned on,
Right, right. They're
they're
not
not
into
turned
this.
on.
Right, right, right. But
Right.
their body's doing something that doesn't match.
Exactly.
Yeah.
And the other way is when men get those erections at night, right? They're not really turned on when they wake up in the morning. That's why they wake up in the morning with that. It's not a I have to go to the bathroom. People think it is. It's just a
Yeah.
coincidence, but they wake up with that erection. Now they could get that cue like, "Hey, I got an
Yeah.
erection, so I'm ready to go." But they are not turned on in the middle of the night. They are
Right,
having the
right.
erection as a physical response. So I think that's really helpful for couples to understand, partners at least, and to really shift in terms of how they both view themselves as erotic allies rather than like, I think men so much take responsibility for the whole sexual interaction
Mm.
and thinking like, this needs to go right. I got to get an erection. I need to make sure
I
she
got
works.
I
I
got to
need to,
perform. I hate that word.
exactly.
Yeah.
It's hard. So instead, don't look at your partner as an audience. Look at your partner as an erotic ally.
Yeah.
That need for communication is really important in the moment, out of the moment. And there is little grief and loss again because people are giving up that go-to efficient sex. Like a lot of
Yeah.
people are like, well, this is what we do. We do this,
Right.
and then we do this. I want to piggyback my arousal off of hers. So I like her to orgasm first, and then I'm going to orgasm. And then they have a whole, like, definitely an order of events, right?
Yes, yes, yes. There's a recipe or a script or a yeah, a rut,
Yeah.
perhaps.
And
Yes.
instead, we're looking for a space of exploration, right? You got to not look at it as like, what is going on with us? What is wrong? This is not working.
Yeah.
You got to think, okay, what can we do, right? What can we do?
Yeah. I mean, one of the things I think, and you're right, cancer is such a scary word, and this is really a big deal. And I think whenever we face challenges, there is a gift of getting to like recreate and explore. I mean, I don't want to minimize the distress and the hardship of this. And there is this positive of getting to work with a partner or ourselves and like rediscover and redefine and create from scratch. And, that's a
I,
hopeful process to me.
yeah, I agree with you. I think that, you know, this process can be, I've seen it actually really connect people because they're going through these things together, and it's a harder space for both of them for different reasons. But at the same time, I've also seen it add insult to injury, right?
Yeah.
And so it's the same thing like when we have difficulty beforehand, right? And so there may be, I'm just making this up, but let's say there's issues around the man initiating already, which could be
Right.
possible if he's got this going on. And then oh my goodness, now how are we going to do this at all? Like, I
Right.
mean,
Right. Yeah.
yeah,
All
I
right.
think,
So, oh, go ahead.
yeah, I think of if I were going to just say the biggest challenge for the men with the prostate cancer, I think that is they really worry a lot about pleasing their partners, right?
Mm.
They really should get on your podcast and look at um, Lori Mint's one on the orgasm gap and how really we know that women, usually only 25% of women orgasm from penetrative sex. We think it has to do
At the
with
most. Yeah.
at the most. And it's
Right.
we think it's the distance between the urethral opening and the clitoris and the vaginal opening. We kind of
Yeah.
think if less than 2 centimeters, it may be more likely to happen. So men, what the message is you absolutely don't want to underestimate, quote, the word foreplay, which every sex therapist hates,
Right.
and really kind of and it's also hard for men who are partnered with men because if the man with the prostate cancer is the top. In other words, we know all men that are gay don't have anal sex, but if they
Right.
do, that can be very difficult if that man is the top and he's typically the one who is providing the anal sex. So that is also a lot of pressure because kind of, that's a big piece of that
Yeah,
dynamic.
right. The way it has gone, right? The thing we're used to, the thing that was sort of reliable historically. And now we
Yes,
have to reinvent. Yeah.
that's right.
Yeah.
The thing I think is the hardest that comes up in my office for partners is around initiation because if the person with the prostate cancer, let's say he's on that androgen deprivation therapy and he has less desire, he really needs to understand that response of desire because if not, he may not initiate as assertively. Like the man with
Yeah.
cancer may need to work on more of an assertive initiation because, and this is not correct, but the partner of that man would be thinking they feel maybe sad because they're equating the assertive initiation with desire. So like
Right.
I'm
Right.
not turning my partner on. If I'm the partner, I'm not turning my partner on. I'm not desirable. And so it becomes, it is very foreign if the man is like, this is very strange. I'm used to having this desire all the time. It
Yeah.
runs my mind all the time, and now I'm not. So it's like the need
Well,
to.
it speaks to the difference too in initiating. If you have that kind of spontaneous or what I call proactive desire, you're already aroused, turned on. Sure, I'll initiate. But somebody with responsive or reactive desire can initiate, but it's not going to be out of that lust and arousal. It's going to be out of intention.
Exactly. And I
Yeah.
think sometimes people think that the other person should engage for the same exact reason they're engaging. You know what I
Right.
mean?
Right.
Like people engage and connect for lots of different reasons. And
Yeah.
so, and it's not any less valid if it comes up because they want to be with you,
Yeah.
they
Yeah.
want to be with you.
Yeah.
So if I were just going to give like tips to couples, I would say you can acknowledge that sex has changed and express feelings together about the grief and loss and the loss of past easy go-to sex. And you are still keeping those positive you're still having the ability to have sexual connection and intimacy. And you can do that together, right? They can communicate new sexual interests and preferences and try to be open to feedback and have a willingness to experiment, explore, and understand really what is healthy sexuality. Because maybe somebody hasn't had that conversation if they've been together
Right.
for and they need to learn to tolerate awkward interactions as they go, as they learn together.
Yeah.
Partner with prostate cancer wants to make a commitment to practice that, do the penile rehab every day, and they're working to really embrace, I would say, embrace a different repertoire to connect and think of themselves as allies, that they're actively working to be patient and give the benefit of the doubt,
Yeah.
really.
Yeah.
They still have orgasmic ability, you know, and the ability to be connected. So
Yeah.
they don't want to give that up because everything's not perfect.
Yeah. Great, great advice. So where do people find you?
I'm thinking sometimes I don't know where I find myself.
That's a harder question than I meant that to be, right? Yeah. Where do people
Yeah,
look you up online, connect if they want to
yeah,
work with you, that kind of stuff?
I know. And I saw you had an Instagram. I was supposed to put my Instagram information. And honestly, I think that I don't do that a lot because I haven't figured out how to put articles on there. And I
Yeah,
tend to
yeah.
post
That's okay. Yeah.
articles. So I am in process with that myself. But jennifervalley.com is my
Okay.
website. And I do, like an old person, still posts on Facebook and Twitter. And I promise to give to a commitment to your listeners that I will get myself on Instagram with the help of my three boys.
Right, exactly. The kids can help, right? Well, thank you so much.
Yeah, thank you. I really admire what you're doing, Jessa.
Oh, thanks.